Well, hello everyone. I wanted to get into the next part of this material on children and mental health and spend some time talking about just two categories here, one of which is anxiety disorders and the other is depression. Now, if you haven't seen the opening video yet on some basics as far as comorbidity rates, prevalence rates, I ask that you watch that first, especially because it talks about other issues such as ADHD, behavior problems, conduct disorders, oppositional defiance, what is normal, what's not normal, and some of the different ways they treat it. Okay, I really would recommend you watch that one first before you get into this one here. But nonetheless, let's get started. Now, as far as anxiety disorders go, children, this is can be a little bit difficult, as I understand it, for some counselors and for some parents because they never want to see their children scared. The fact of the matter is that those kind of things do happen to children, but a disorder basically consists of what we call highly elevated levels of nervousness, highly elevated levels of worry and tension and things like that. I say again, fears are common in children, worries are common in children, and one could actually say they are healthy because they protect us. They protect us as children. They protect us as adolescents. If we get a little nervous and scared, hopefully discretion becomes the better part of valor and we step away and keep ourselves from getting into a dangerous situation. With anxiety disorders, however, these tend to consist of persistent fears, constant fears, and sometimes intense fears that really are not that threatening. Okay? That really are not that threatening. They can include phobias, all right, where a level of threat is low, but the fear level is quite high. They can consist of just anxiety disorders in general, panic attacks, and things like that, which sometimes have very little, if any, basis for them in that regard. As far as causes, heredity can be a cause for some anxiety disorders, but the vast majority of them are learned. Okay, they are learned. They are due to the environment. Much more the case in that regard is that they are brought on by the environment. And sometimes what happens is they learn it from somebody else. They learn to be scared, and because they see someone else scared. We've seen cases, I understand, of kids suffering from anxiety disorders that are unjustified because they watch a movie, they see a parent, they see someone else who means a lot to them act very frightened in some situation, so they become very scared of it. A child may never have a run-in with a snake, but they see how mom and or dad responds to a snake, and so they learn that fear through them. It's called vicarious conditioning. Vicarious meaning learning by observation. So a lot more of it is due to the environment than it is through heredity. And actually, that's a good thing because if it is something that they have learned, they can unlearn it. As far as treatment goes for a lot of this, there are many different types of treatment. There are a handful of different types of treatment. One of the biggest is called systematic desensitization. And this really is best handled by a professional. It's not something I would recommend to a person to try on their own with their children. You have to be extremely careful. The idea behind systematic desensitization, some call it SD for short, is that you basically expose a person to that which frightens them, but you do it very slowly and you do it in very small amounts and let them get used to it. And then you increase the exposure, okay, and let them get used to it at a higher exposure and then so on. I have seen this done with a couple of different things. I saw it done once with a counselor who had a child who was suffering from hydrophobia, which is fear of water. And what they basically did was work with the child by having them sit on the very edge of a swimming pool. While all the rest of the kids were playing in the pool, this child was scared of the water. And they sat on the very edge of the pool and put their feet in the water on the steps. And after splashing around there for 5 or 10 or 15 minutes, then the child increased the exposure by sitting on the very first step. So now the water was coming up to their legs, and they were in that position for about 10, 15, 20 minutes. And then they went to another step. So the water came up to about their chest. And then eventually you just kept increasing the exposure till finally the child had to trust in the counselor to hold them tight and bring them out into the water and make them realize it wasn't so bad. And the child actually did overcome it. I believe it took close to an hour of slowly increasing the exposure. You're in the water a little, then you're in the water more, and so on and so forth, till eventually you realize it's not so bad. All right. There is another approach, which is sort of a complete exposure. The term for it is called flooding. It does have some other names as well, but flooding is a type of treatment. Flooding is a type of treatment where you expose someone to their fear outright. And the goal is not to torture them, but to make them aware it's not as bad as you might think. And I will just sort of leave it at that. It's something that you really don't want to do unless you're a trained professional. I don't want people exposing their children, their sons, their daughters to something outright and say, here, get over it, because it can actually make it worse if you're not too terribly careful. I want to also turn around and talk about depression, okay? And when it comes to depression, this can actually be somewhat difficult to diagnose in children because it can be hard to confuse sadness for what we would call clinical depression in that regard. If it's mild, then it's sort of easy. And then if it's severe, if it's severe depression, then it's sort of easy to say that there's a problem. If it's mild, even moderate, it can be a little bit more of a challenge. Children have down days. Adults have down days. It does happen. How do you differentiate between a child who has a bad day or a bad couple of days versus a child who is clinically depressed? There are an awful lot of symptoms, and I don't list them all here, but I will share them with you, some of the different symptoms to keep an eye on. Children who turn around and their friends start to disappear. Okay, they don't hang out with their friends anymore. They have feelings of helplessness or feelings of hopelessness. Okay, they feel helpless and they have no sense of future involvement. They feel hopeless. Grades start to drop. They lose their appetite. Sometimes they eat all the time. Sometimes they sleep a lot or they don't sleep at all. And probably one of the biggest ones, and I could go on with lots of different symptoms in this regard, is talks of death and suicide. And you even have to be careful with that, because if a child turns around and talks about death, I always ask, why are you interested? Are they suicidal? Are they depressed? Or are they just trying to better understand what death is? Okay. But there's a lot of symptoms: feelings of helplessness, hopelessness, weight loss, weight gain, excessive sleepiness, friends disappear, grades tend to drop, tardiness at school, that kind of stuff, and more. Most of these symptoms, one symptom is not enough, okay? Usually there are 4 or more symptoms present before a therapist or psychiatrist or clinician will start doing a diagnosis. Bad grades in and of itself are not enough, especially if, say, that's the only thing. and I've been told by professionals that just because you have, say, 4 characteristics or 3 or 5 does not automatically mean childhood depression. As I put there, 4 or more symptoms typically may indicate a potential victim of childhood depression. It is not a guarantee that the child will suffer from depression in that regard. And so you have to be very, very careful of it in that case. A lot of times, the only exception to this is suicide. If a child is suicidal, if they talk about killing themselves, if they talk about how life would be better if they were dead, and they genuinely seem interested in taking their own life, we don't have to We don't have to wait for 3 more symptoms to appear. If they're talking of being suicidal or have tried to hurt themselves, then once again, we act upon it immediately. We have to see this go on for 6 months or 3 months or 2 months or any of that, if that should happen to be the case in that regard. Now, as far as I said this before, as far as diagnosing children, moderate to severe cases of childhood depression are a bit easier than the mild cases because it's sometimes hard to determine. And so if you have a child who you wonder if they have a mild case of depression, if at all possible, I would suggest seeing some professional. There are places that have sliding scales of cost based on income. You are always welcome to contact me by email or otherwise, and I will put you in touch with somebody if necessary. But there are places here in town, in Springfield and the surrounding area, that offer such services as well, and it wouldn't take much to reach out and find them. Burrell at Cox, the Marion Center at Mercy, and even others have programs as well. As far as treatment goes, a lot of times with the treatment of childhood depression, there is individual counseling, one-on-one counseling. Sometimes it's meant to change how a child thinks. We've actually seen cases where children think irrationally, and through individual counseling make them realize that their thinking is not healthy. Sometimes it's dealing with the emotions, but it's done individually. Okay? There are times that the problems for depression stretch beyond just the child. I've been told that there are cases where a child shows signs of depression due to unhealthy thoughts and behaviors, and really the true cause is within the family. And you have to sort of treat the whole family. You can't just treat the child in question. And the same can be said with conduct disorders and things of that sort. I mentioned that in the prior video. Family counseling can become a big part of it. And then finally, there are medications, the Prozac, there are antidepressants, SSRIs, tricyclides, and so on. You don't need to worry about the different types at this point, MAO inhibitors and things of that sort. But there are different types of medication. Some parents are very leery of giving a child antidepressants. I guess I'm one that if a child is severe enough to require some kind of medication, that I would trust a doctor to diagnose them properly with the proper med and go from there. Be aware of this. This may sound crazy, but sometimes determining the best medication, especially for childhood depression, is very hit and miss. And that means they'll try a medication, and if it does not work as one would hope, they'll try another. And if that doesn't work, they'll try another, or they'll try a different amount. And sometimes you sit there and wonder, now, how did this individual ever become a psychiatrist? My God, it's all hit and miss. Well, the body is a very complex piece of machinery, and trying to get it right doesn't always happen on the very first try. And so you have to be a little bit patient with them. Some people have up and quit and left treatment, which is sad, but be understanding if you have a doctor who is trying very hard to get a child on the right antidepressant and keeps upping the dose or lowering the dose or changing to a different med. It does happen, and it is necessary. Okay, that's enough for now. Keep up the good work.